Auditory middle latency response, AMLR, or simply MLR. MLR contains a series of negative and positive peaks, starting from N0, which is not labeled on this graph, but is located right at my laser pointer, N0, followed by P0, and then NA, PA, NB, PB, NC, PC. There are 4 pairs of negative peaks and positive peaks. So N0, P0 being the first pair, NA, PA the second pair, NB, PB the third pair, NC, PC the fourth pair. In reality, the N0, P0 components usually are not easily identifiable in MLR recordings. However, for NA component, it usually is identifiable and visible in MLR recordings. As a result, you usually can see the NA component following the wave 5 or wave 6 of ABR recordings. PA is the most robust component in MLR. He is the big guy, so we want to pay attention to this component. PA is the most robust component in MLR. Typically, if you count the interval from ABR wave 5 to PA, it's roughly 25 milliseconds. However, if you compute the absolute latency of PA, it's about 30 milliseconds because you got to include the latency of ABR wave 5. Another issue or fact you need to understand is the PA-NB component or PA-NB complex are not affected by muscle relaxant. In other words, if a patient is receiving muscle relaxants from the doctor, MLR responses will still present. However, if the brain falls asleep or the patient is under general anesthesia, the MLR will be gone because MLR is endogenous. It requires the brain to remain awake. The fact here we mentioned PA and B complex are not affected by muscle relaxant is referring to a situation that sometimes the doctor will inject muscle relaxants to relax muscles on the patients. The patients are still awake. Then in that case, MLR will still be present and not affected by muscle relaxant. However, and again, if the brain falls asleep or the patient is under general anesthesia, then MLR will be gone because MLR is an endogenous response. For MLR, as we mentioned, and as you know now, it contains a series of slow peaks, about 40 Hz, intervaled by 25 milliseconds, that follows immediately after ABR. Usually they are labeled as N0, P0, NAPA, and NBPB. The most prominent components include NAPA and NB for lower signal frequency and slower stimulation rate. So what do you mean lower signal frequency? If you look at the left-hand side of this graph, the MLRs are evoked by 500 Hz tone burst for the top waveform. As you can see, we have NA, PA, NB, and PB. If we elicit MLR by using 4000 Hz tone burst, we get MLR like this. You still see NA, PA, and NB, maybe PB, but their amplitudes are not as big as 500 Hz. If you use clicks to evoke MLR, you get something like this. As you can see, MLR prefers low frequency stimulation. So when we compare click 4000 Hz and 500 Hz stimulation, 500 Hz produce the most robust MLR. So in other words, MLR prefers lower stimulation frequency, lower signal frequency. Then what do you mean slower stimulation rate? Then now let's look at the graph on the right. On the right shows 3 MLR waveforms. On top, it presents a stimulus 0.5 times per second. The middle graph shows stimulation rate 2.1 stimuli per second. The bottom one shows 5.1 stimuli per second. So as you can see, the stimulation rate increases from top to bottom, 0.5 up to 2.1 up to 5.1 stimuli per second. However, as we increase the stimulation rate, MLR components decrease. In other words, MLR prefers a slower stimulation rate. In other words, if you want to obtain a robust MLR recording, you would use a low frequency stimulation and use a low stimulation rate, and that will produce the most robust MLR. Again, use a low frequency stimulation and present the stimulus at a low stimulation rate. That will give you the most robust MLR components. Here is another slide showing the MLR contains a series of slow peaks that follows ABR. They can be labeled as N0, P0, NAPA, NBPB, and even NCPC. And the graph at the bottom is kind of blurry and not very clear. My apologies. But I'm trying to show the idea that MLR components follows ABR wave 5, which is circled here. As you can see, that we have N0, P0, NAPA, and NBPB. These major MLR components following the ABR wave 5. Here is another graph I copied from a textbook showing the MLR components following the ABR. And for this graph, it's pretty old, so they plot negativity upwards. In other words, positivities are downwards. So ABR 1, 2, 3, 4, 5, and 6. And followed by the MLR components, N0, P0, NAPA, NB. PB sometimes overlaps with the cortical response, LLR, we will mention later. And the NCPC usually are not clearly identifiable in recordings. And again, this graph shows the MLR components here. And as you can see, it kind of in the middle between ABR and LLR. So it's in the middle. That's the reason people call it middle latency response. It's somewhere in the middle between ABR and LLR responses. In terms of the neurogenerators of MLR, it is commonly believed that NA components are coming from primarily thalamus, and PA components are coming from primarily the primary auditory cortex or the precortical structures. And the table on the right is a copy from an old textbook, and it shows the neurogenerators for ABR, MLR, LLR, and other responses. For this class, no need to pay attention on the table on the right. It's a bit out of date. For the topic of MLR, all you need to know is the two generators for NA and PA. For NA, it's coming from thalamus primarily, and for PA, it's coming from primary auditory cortex or precortical structures primarily. This table shows the stimulation and recording parameters for recording FFRs. For transducers, it's almost a convention that we use insert earphones. For the different types of stimuli, we can use clicks, long-duration tone bursts, or human speech. If we use tone bursts, then we may include rising and falling phase for about 2 cycles of the carrier frequency. And the plateau portion may contain multiple cycles of the carrier frequency. And again, the brain prefers long-duration tone bursts. If we are using tone bursts, slightly longer durations are preferred than short durations. For the stimulus rate, As it is shown in the previous slide, MLR prefers a stimulation rate slower. So if you do the stimulation rate higher, faster than 7.1 stimuli per second, MLR will be highly compromised or even gone. In other words, if you desire to record MLR, you want your stimulation rate to be less than 7.1 stimuli per second. Polarity of MLR does not really matter. As a matter of fact, for cortical responses or for endogenous responses, polarity does not really matter too much. For MLR, it does not matter at all. For stimulus intensity, moderate intensity levels are preferred, such as 75 dB SPL. If you present the sound too loud, the brain may feel hurt and give you degraded responses. You want the brain to feel happy and comfortable. As a result, moderate intensity levels are preferred, such as 75 dB SPL. Masking noise to the non-test ear usually are not necessary, especially when insert earphones are used. For the recording parameters, we set the gain to 75,000, as you are aware that if the 75,000 gain is smaller than 100,000 that we set for ABR, SSR, and FFR. For MLR, because MLR amplitudes are much bigger than ABR, SSR, and FFR. As a result, the gain can be set to a smaller number. The benefit of setting the gain to a smaller number is that we will get a wider range for input range. The input range can be wider, and that is beneficial. So in other words, when recording MLRs, you can set the gain to 75,000. It's enough. You don't have to set it to 100,000. In terms of the recording time window, we record 10 milliseconds before the onset of the stimulus, up to 100 milliseconds after the onset of stimulus. For MLR, and almost as a convention for cortical responses, we always record a segment of EEGs that is before the onset of stimulus. This segment is called pre-stimulus segment. The pre-stimulus segment gives us an idea of what the EEG looks like before the onset of a response, and that pre-stimulus segment provides a baseline. It serves as a baseline for us to identify the MLR components and to pick the peaks. So that's the reason we include a portion of a pre-stimulus segment. In this case, we include 10 milliseconds before the onset of stimulus. So we name it negative 10 milliseconds. We record down to 100 milliseconds because we want to capture all MLR components as possible. The number of sweeps, we don't need to go higher than 1,000 sweeps because MLR amplitudes are bigger than ABRs. For ABR, SSR, MLR, we usually have 1,000 sweeps or more. But for MLR, you really don't need that. 1,000 sweeps is plenty. Maybe 500, 700 sweeps will do. So you do the number of sweeps to less than or equal to 1,000 sweeps is sufficient. For the filter setting, you can set it to from 10 Hz to 1500 Hz. Or you can set it to from 5 Hz to 1500 Hz. Or you can even set it to between 10 and 200 Hz.
However, if you set it to between 30 and 100 Hz, it will not work. I will mention the reason in a little bit. So as you recall, the frequency component of the MLR is roughly 40 Hz. And so all these filter settings can capture 40 Hz. That is correct. However, we also need to consider the width of the filter range. For example, if we set it to 10 to 1500 Hz, it's a fairly wide filter setting. Same thing for 5 Hz to 1500 Hz. The filter frequency range is fairly wide. Even if you do from 10 to 200 Hz, it's not ideal, but it's okay because it still is wide enough. However, if you further narrow the filter range, for example, down to as narrow as from 30 to 100 Hz, it's fairly a small, narrow frequency range. Such a narrow filter range will have consequences. Specifically, it will produce ringing artifacts, which we will mention in a later slide. In terms of locations of the recording electrodes, we would like to put it in the frontal central area, which is usually we put the electrodes on FZ or CZ or PZ. It's all within the frontal center, the central line of the head. For the ground recording electrode, it can be anywhere. As long as it's somewhere along the midline, we are good. For example, we usually put it on the low forehead, FPZ. For MLR, we also need to put a pair of two recording electrodes to monitor eye blinks. Because again, when recording MLRs, the participants are awake and their eyes usually are open. So we will need to have separate recording electrodes to monitor eye blinks. When recording MLRs, the patients are instructed to remain awake. For filter settings, if you only want to see MLR, then you can set the filter settings to, say, between 10 and 200 Hz. On the other hand, if you want to see both ABR and MLR, you can use 10 to 1500 Hz or 5 to 1500 Hz. Again, MLR frequency is around 40 Hz. The narrow frequency range, for example, from 30 to 100 Hz, such a narrow filter range will produce ringing artifact. Again, we will discuss in a later slide. Thank you.
This slide shows an actual recordings for MLR. On top shows 3 replications of MLR. As you can see, the MLR components are replicable among the 3 replications. And as you can see, the PA component is the most robust and component in MLR. When you average the 3 replications, you can see the PA component is the most robust component. And ABR Wi-Fi is about here. We also can identify an A and B components. At the bottom is showing the control recording when the sound is not audible to the participant. These are just simply control recordings where MLR is gone. So MLR, you can also see the PA component amplitude is much bigger than Wi-Fi. So PA amplitude is usually bigger than Wi-Fi. And that is the reason we can set the gain to 75,000 only. and we don't need more than 1,000 sweeps recording. This slide shows a growth function for MLR. These MLRs are recorded from a normal hearing woman. The recording shown on the left-hand side column A, are MLRs with multiple replications. As you can see, MLRs are recorded at 50 dB NHL down to -10 dB NHL. And the waveforms on the right shows the average of the MLRs. As you can see, at 50 dB NHL, the MLR component, the PA component, is fairly clear here. 40 dB NHL, PA component is still present. 30 dB NHL, still there. 20 dB, still there. 10 dB NHL, it's hard to tell, and you can say no, it's fine. So let's say no MLR at 10 dB NHL. 0 dB NHL, no response. -10 dB NHL, no MLR. So if you look at the MLR growth function and find the PA component of the MLR, it's probably 20 dB NHL is the MLR threshold. For this woman's behavior threshold to clicks is 10 dB NHL. And MLR threshold is, say, 20 dB NHL. It's very similar to ABR. The MLR threshold is about 10 dB higher than the participant's behavior threshold. In other words, ABR can be used to predict the person's behavior threshold, just like as we did for ABR by using ABRs, ASSRs. So MLR can be used to predict behavior thresholds for the participant. Same thing as we would do by using ABRs and ASSRs. However, if you are using MLRs to predict behavior thresholds or simply to record MLR, you want to make sure the stimulation rate is fairly slow. It must be slower than 7.1 stimulation per second. And this puts the MLR to a disadvantage because slower rate means longer recording time. And while ABR can go up to, say, even 20 or 30 stimulation per second, if you use MLR, the stimulation rate must be slow, and that will make the recording time longer, which is not as good. And for this reason, the MLR is not popular for predicting behavior thresholds. But I just want you to know that if you want to, it can be used to predict behavior threshold. It's just not as good as ABRs. For this recording, they used the filter setting from 5 to 1000 Hertz. So the ABR waveforms are not clear. You see a little bit of it, but not very clear because of the filter setting. In this case, they want to focus on MLR components only. Here is another slide showing the MLR growth function, the amplitude series. When the sound is 40 dB HL, we can see NA and PA. When it's 30 dB HL, we can also see identify NA and PA. 20 dB HL, we still can identify NA, PA. However, when the stimulus goes down to 50 dB HL, we cannot see MLR. So it's not shown here, but the threshold for the MLR threshold is actually 17.5 dB HL, which is not shown on this graph. The slide is trying to show you that it is possible to use MLR growth function by measuring the amplitudes across a series of MLRs produced by different intensities. And from there, we can identify MLR thresholds. And from there, we can predict thresholds for the participant. Recording montage. This slide shows an example of two-channel recording montage. This is different from the one-channel recording montage that I mentioned in an early slide. So this slide shows an example of two-channel recording montage. The setup and the locations of the electrodes are quite complex. So let's start from an easy one, the ground. The ground electrode is very easy. You just find somewhere along the midline, usually say the low flow head, FPZ. So FPZ goes to the ground. So this one is easy. We can get it get it settled right away. For the two-channel recording, the positive and negative recording electrodes, they start from the right-hand side channel, the first channel. They say the positive one, we can put it on C4 if you want. So the positive recording electrode will come from C4 and go to the positive slot on the first channel, which is A slot. A slot is the positive slot. So C4 goes to the positive slot. Then the A2 can go to the negative slot because A2 is on the same side of C4. However, for the two-channel recordings, we want to consider the symmetry of the head. We don't want to be biased toward one side or the other. So as a result, we have another recording electrode on A1, the left mastoid or left auricle, and that will go to the negative slot of the second channel. And in this case, the A1 and A2 recording electrodes will be connected through a jumper cable. This jumper cable is a bridge. It makes the A1, A2 becoming one single electrode. They are merged and become one. So A1, A2 are merged, or they say joined, inverting electrode. So A1, A2 are merged and then go into the negative slot on the first channel and also go into the negative slot on the second channel. In other words, the EEG is coming from A1 and A2 are merged and becoming one EEG. And that merged EEG will go to the negative slot on the channel 1 and also go into the next negative slot on channel 2. So in this case, the negative recording electrodes are merged through a jumper cable. Okay, that's for the negative recording electrode, the inverting electrodes. For the positive electrode we mentioned on the right-hand side with C4, that's quite straightforward. That goes to channel 1, positive slot. For the left-hand side, they say we put it on C3, and that C3 will go to the positive slot on channel 2. And ta-da, it's done. Now you have settled the positive and negative electrodes and also the ground for two-channel recordings. The same principle applies to all locations on the scalp. It's just a matter that the negative electrodes are coming from the two mastoids. The two mastoids electrodes are joined together through a jumper cable. And in this case, people often call it a joint reference for the two mastoids. We mentioned briefly about the effect of stimulation rate on MLR. This slide shows you more details about that. So the stimulation rate was 10 stimuli per second and then decreased down to 1 stimuli per second. As you can see, the MLR components, the NAPA components, increase when we decrease the stimulation rate. So at 1 stimulation per second, the NAPA is the most robust. So this slide is trying to show us that if you want to obtain the best MLR, it's highly recommended you use the stimulation rate about 1 stimuli per second. Even though I know on the table we want you to set the rate less than 7.1, but that's kind of the bottom line, the minimum requirement. If you want an optimal MLR responses, you want to use the stimulation rate around 1 stimuli per second or 2 stimuli per second. If you go higher than that, the MLR components will be degraded substantially. If you go higher than 7.1, it's very small or even gone. So this slide is trying to emphasize that if you want to enhance MLR responses, it's highly recommended you use 1 or 2 stimuli per second. This slide shows the ringing artifact produced by a narrow filter setting. These recordings are made from a 2-year-old patient who had severe temporal lobe dysfunction due to a stroke. So on the left-hand side, on the top left-hand side, we see a recording, and the filter setting is 30 to 100 Hertz. Now you know immediately, oh, it doesn't look right, but this is the recording if we set the filters like this. Then we will get something like this. Then if I don't tell you the filter settings, you will look at, hey, this looks like a PA component. However, if you widen the filter setting to, say, from 5 Hertz to 1500 Hertz, then that hump is gone. If that hump is truly MLR component, it should stay. When we widen the filter setting, MLR should stay. It shouldn't go away. The reason it goes away is because what we see on the top waveform is not MLR PA component. It's a ringing artifact. And this is the evidence. Because as you can see, when we widen the filter settings, that thing is gone. So that thing is not the PA component. On the other hand, if we use a narrow filter setting, such as 30 to 100 Hertz, we could produce an artifact that looks very much like the PA component. We don't want that to happen. We don't want such confusion. As a result, don't use a narrow filter setting. It will produce ringing artifact. The bottom waveform shows a recording from another patient, which is totally normal, and then we can see the NAPA and BPB. So just so you know that this slide shows the ringing artifact produced by a narrow filter setting. Another issue that we need to discuss is post-auricular muscle artifact, PAM artifact. So the PAM artifact may look something like this, as shown on the top waveform. And if we are careless, we may accidentally say, hey, this is MLR, we have the NA here and the PA after. So for a normal and true MLR components, they look something like this, as shown in the lower waveform. We have NA, PA, and BPB. But you may ask me, Dr. Juan, how do I differentiate whether it's PAM artifact or MLR components? One little trick is that the peak, the first peak for PAM artifact usually is less than 20 milliseconds, whereas the PA component usually has a latency greater than 20 milliseconds. That's one easy way to tell by latency. Another easy way to tell is the muscle artifact tend to have a morphology looks like this, and the amplitude is so sharp and so dramatic. It looks kind of too good to be true. It's like, how can you have a skyscraper built on a cornfield? It just doesn't fit. It doesn't look right. So, but the actual measurement to give you a hint is the latency. The PAM artifact peak usually occurs before 20 milliseconds, whereas PA component latency has a latency after 20 milliseconds.